So we've already mentioned that what happens to the ovary is it develops cysts. Far and away, the most common cysts that develop are the physiologic cysts associated with the normal menstrual cycle, or sometimes the cycle becomes a bit confused and you no longer have a normal cycle, and this is because of the associated hormones, typically estrogen and progesterone, that cause the cycle to become abnormal, and you develop what we call functioning ovarian cysts. So far and away, these are the most common. Now, again, thanks to Dr. Nitter's beautiful diagram, we can see what happens to an ovary in a cycle. Immediately after menses, there are no dominant follicles, but by the time day 14 rolls around, we develop a follicle that is typically larger than the others and has the egg or cumulus within it. After ovulation, we then develop the corpus luteum. Whenever I do a gynecologic scan, I always ask the patient two questions. One, when was your last period? And two, are you on hormones? Because I want to tie what I see on the ultrasound exam to what her responses are relative to where she is in her cycle. And I know that follicles become their largest just prior to ovulation. They can become as large as 30 millimeters, and they're associated with estrogen production. And here we have case number 1 on day 14 showing a follicle with a little cumulus. So how do I report this? Well, this is a normal finding for this woman. We'll talk about in a minute a recently published consensus as to how we should address this situation. Now, right after ovulation, you develop the corpus luteum. And I put the word cyst here in quotations because, as we can see, that cyst quickly involutes to become more or less solid looking. But we need to recognize them. They also can be up to about 30 millimeters and are associated with progesterone production. And here we have case number 2 of a corpus luteum immediately after ovulation or shortly thereafter. Notice the thick, irregular, crenulated wall. If I was to put color on this, there would be flow within that wall with a low resistance pattern. As the follicle matures, it involutes, becomes more solid looking, and if you were to put duplex on, you would see the color is only in the periphery with a low resistance flow that in every way can mimic a neoplastic flow pattern. But be careful, because if the history and the appearance on the grayscale are consistent with a corpus luteum, this is a normal finding in a woman who is ovulating. Now, sometimes the cycle doesn't continue normally. You may fail to ovulate, you may fail to involute a corpus luteum, or you may hemorrhage into it, in which case you may end up with what we call a functioning ovarian cyst. And the word functioning implies there is an excessive amount of hormone in the neighborhood, progesterone or estrogen, for the corpus luteum and the follicle, respectively. So starting with a follicle, a functioning follicle is one that is greater than the 3 centimeters that I talked about before, and it would be in a patient who often may fail to ovulate, and you're left with this large follicle cyst or functioning follicle. The corpus luteum may hemorrhage, may even, the ovary or the cyst may actually rupture, and you can get even a large hemoperitoneum in association with these functioning corpus luteal cysts. So here we have a functioning follicle. It measures roughly 3 by 5 centimeters. It's simple, and given time, usually a few months, this should involute. Here we have one of the appearances for a hemorrhagic corpus luteum. This is associated with increased progesterone, and also given a few months, this will involute. The third kind of functioning cyst is seen here, where we see multiple large peripheral cystic structures or follicles, and these are seen in certain conditions where there is a milieu of increased HCG on board, and these are follicles then that are stimulated, and all follicles live in the periphery pretty much of the ovary. So that's what these are, and they're stimulated by the HCG to get large in a patient who has, and you need the history here, either been given HCG in an effort to become pregnant, perhaps overshot the mark and had the development of a multifetal pregnancy, in which case each placenta will in itself elaborate HCG, so again, an excessive amount of HCG on board to stimulate the ovary, or a patient who has one form or another of gestational trophoblastic disease, such as a classic mole, or even down the range of these conditions to choriocarcinoma. People who have too much HCG on board, I'm sure you know, can be prone to have fluid collections in the way of ascites, pleural effusions, or even pericardial effusions. These patients are treated depending upon the etiology for their fecal lutein cysts, and in many cases, particularly the top two, it's watchful waiting. So in late 2009, a group of many people with great experience in ultrasound and interest in ultrasound convened with the Society of Radiologists in Ultrasound meeting for a 2-day consensus conference addressed to what we should do with ovarian cysts. This was in late 2009 in Chicago, and Debbie Levine, who's currently one of the editors of Radiology, wrote the paper that has now been published in at least 3 places that I know of. One is Ultrasound Quarterly, another is Radiology, and the third one, I believe, is in the gynecologic literature. And basically, we're trying to disseminate this information, as I said, from experts in radiology, sonologists, gynecologists, pathologists, so many, and statisticians, so many people who are interested in the business of what to do with many of these cysts. So what they addressed and said with respect to premenopausal cysts, what do you do about them in terms of follow-up? Their suggestion is if it's a simple-looking cyst, 3 centimeters or less, probably don't even need to report it, and certainly don't need to get a follow-up, because these are normal physiologic cysts seen with the normal menstrual cycle. Now, what's confusing is if you see a cyst in other organs like the liver or the kidney, that's not normal. But I want to emphasize the point made by many of us at that conference: cysts are normal in the ovary, and so if it's normal, don't mention it. But make sure you know the patient's history with respect to 1, when was your last period, and 2, are you on hormones? And knowing where you are in the cycle, and assuming the history is she's not on hormones, you should be able to figure out if you're dealing with a physiologic follicle. If it's between 3 and 5 centimeters, it's probably going to be a functioning follicle, in which case you know it should disappear in a period of a few months. The people who are addressing this meeting agreed that we should put this in the report, but no need to follow it since they should go away. It's only those larger cysts, somewhere between 5 and 7 centimeters, that should undergo a yearly follow-up. And we'll talk more about this again as we continue in this lecture. But 7 centimeters appears to be the recent newly announced cutoff for when we should start to intervene, perhaps because of the threat of torsion when things get that large. A hemorrhagic cyst should be treated in the same way as a physiologic follicle, in that the small ones we can ignore in terms of follow-up, perhaps report the larger ones, but they too should disappear within a period of a few months. The larger ones, probably a good idea to get a short interval follow-up, because sometimes these hemorrhagic cysts can mimic endometriomas. There's a crossover in their appearance, and just to make sure that they do go away then. So it would be a good idea then to follow these. If they stayed, entertain the thought of an endometrioma.